Who's going to be doing that? Okay, there you go. Cool, cool. Thank you. Go ahead, El Hadi.
All right. Yeah, so like I mentioned, I saw this patient about a year ago in Sudan. So that's just a little bit of background information. The chief complaint is of an 18-year-old male presenting with loss of consciousness and several episodes of generalized tonic-clonic seizures. And I'll stop there for now.
Thank you, El Hadi. Um, Hans, do you wanna go first and just tell us what your approach is to the information we have so far?
Yes. So just to repeat, we have an 18-year-old male who presents with loss of consciousness and generalized tonic-clonic seizures. So my first approach for loss of consciousness, it looks like it is fairly sudden. We don't have a time course in the sense of has it experienced the same before? Is it the first time? Did it occur suddenly? What was the history before? But loss of consciousness, we have the 5 S's, and I think we also have the scan mnemonic, and then we have seizures. So that we have to explore further and make sure that these are really seizures and not just a syncope or something else that leads to loss of consciousness. So we might look for the 5 S's, which is sugar. Loss of consciousness may be due to a syncope, due to a seizure. Are there metabolic derailments like electrolyte causes that might cause a seizure or loss of consciousness? And then, of course, we might also look at, and this is quite unlikely because we have been given the hint that there are tonic-clonic seizures. Maybe there are drugs involved which cause a loss of consciousness. And the next step would be to explore whether he has seizures and what might be the cause of his seizures. That would be my first approach. And of course, I should add as well, before I start even thinking, the ABCs. Is his airway stable? Is he breathing? And does he have a stable circulation? And then we can go further with our diagnostic.
I love it, Hans. Thank you. Thank you for reminding us kind of and Tansu for kind of re-summarizing how sometimes when there's altered mental status and sort of a seemingly severe situation, you kind of want to think about immediately life-threatening and immediately reversible causes. That's the scan mnemonic potentially, right? To consider mimickers of actual epileptiform activity, and then thinking about the seizure. So one way to maybe frame the possible etiologies is, there's always a first time seizure of kind of idiopathic epilepsy, right? That has to start somewhere, and it can start at this age. Or there could be causes of secondary seizures, whether those are intracranial processes like infection, like tumor, like bleeds, like strokes, or systemic processes that can affect the brain. And there's a lot of overlap in that with sort of causes of altered mental status, right? Whether those are, metabolic situations, drug effects, et cetera. So we'll kind of get more of a history, which I hope will include more of a time course and a description, a so-called semiology of the seizure, kind of how it started, what it looked like, and as well as kind of a background context of more about who this patient is in terms of their kind of medical identity and risk factors, who the host is. But I think we're off to a great start. El Hadi, you want to tell us the next aliquot?
Yeah, sure. So this was this patient's first seizure. He has a clear past medical history. And the second aliquot, I'll be going into the HPI. So, like I said, he had a clear past medical history. He presented with continuous generalized tonic-clonic seizures and loss of consciousness. Earlier in the day, he had already had 2 episodes of seizures before presenting to us. The patient complained of a fever and neck pain 1 day prior to admission. The fever progressed throughout the day and became more severe and was accompanied by increased fatigability by the end of the day. His father stated that his son had 1 episode of coffee ground vomiting earlier in the day, before the seizures had started. The patient's father sought medical care around 4 hours after the onset of the seizures, and he had went to a nearby hospital where the patient was given broad-spectrum antibiotics and diazepam because they were suspecting meningitis. Then the patient was referred to our hospital, where he was admitted into the ICU, and I had seen him there because I was working at the ICU at that time. I'll go into the other parts of the history, and I'll give that whole aliquot. So his past medical history was negative for sickle cell disease, hepatitis, or any allergies, and he had no previous surgeries. As for his social history, he doesn't smoke tobacco, he doesn't drink alcohol or chew tobacco, which is pretty common in Sudan, and he's a student. He's originally from a low socioeconomic area where he lives, and he has goats and chickens at home. His family history is negative for any similar conditions. And on the systemic review, his father had just stated that the patient was feeling unwell leading up to his presentation, and he had some episodes of diarrhea and abdominal pain. Otherwise, the review systems was completely negative. And as for his drug history, he doesn't take any medication. And his past medical history is negative for sickle cell disease. And I'll stop here.
Wow. What a place to stop. That was an amazingly rich aliquot, a lot to digest. Yusuf, you want to get us started?
Yeah, absolutely. So, like you all mentioned, in the person's first seizure ever, if this patient was 60, for example, we would have prioritized a ischemic cause or a mass lesion. But just by the fact that they're being 18, we were wondering, could this be a primary epilepsy or is this an infection? And them having a fever also increases the probability that this is an infection until proven otherwise, with the fever and the acuity of 1 day. And then in order to prioritize one infection over the other, I would try to think of the patient's risk factors and geography and immunizations and their immune status in general. So upfront, I'm starting to think of I would want an HIV test early in this case to make sure they're not immunocompromised, for example, or one form of immunocompromise. And then I'm trying to think of how much weight do I put on the coffee ground emesis and the diarrhea. Diarrhea is very common in pneumonia, for example. I'm sure it's common in meningitis as well. But the coffee ground emesis is interesting. I've actually had a patient in residency who had a seizure and had tongue biting, and as a result swallowed some blood and then had coffee ground emesis, which is interesting. But because of the diarrhea, the exposure to chickens and goats, just up front, I want to say that I don't know all the infections all around the world. In general, what I do is I open Google and I write CDC, Sudan infections, and you will find the most common infections. But off the top of my head, I learned this from VMR, is that neurocysticercosis is one of the most common acquired causes of seizures worldwide. I learned this from Yasmin. But exposure to chickens and goats, I'm thinking of things like brucella, which in my mind causes high-grade fevers. I'm also thinking of viral etiologies. But before I put my money on an organism, my money is on the lumbar puncture and upfront and empirically treating plus imaging and taking it from there. And obviously a good neuro exam, looking for any rashes or clues that can point us to the direction. And I would try to take a history from the family as well to see if anybody else is ill, for example.
Wow, Yusuf. Yeah, amazing discussion. I love that story of sort of how one can link potentially seizure and then pseudo upper GI bleeding, right? I think the other thing in the history I'd be asking his dad or whoever was kind of reporting the earlier symptoms was, had he had any vomiting along with the earlier abdominal pain and diarrhea? Just because the other way you can end up with blood in your stomach is if you're just having vomiting because you have meningitis, right? And then you have a Mallory-Weiss tear, you sort of tear a bit of your lower esophagus, and then you're bleeding from that. But again, the frame would still be meningitis, which clinically this is, right, fever, neck pain, seizure. Like the patient has meningitis. The question is, does he have some other clinical feature that would tell us about a different sort of process, or maybe prioritize a different organism, if there's also a hemorrhagic component in the GI tract, right? But if this is sort of just like a complication of vomiting or tongue biting, then the frame would be only meningitis potentially, right? So yeah, I think the LP is definitely key in terms of getting information about sort of the type of process around the CNS. But the other sort of thing to think about if there's GI bleeding is what causes of sort of systemic infection, including involving the CNS, can sort of have a hemorrhagic component, and it sort of made me think about some of the hemorrhagic viral syndromes. There's obviously outbreaks of Ebola, but there can also be sort of spontaneous. There are spontaneous cases that we never hear about that don't become sort of microepidemics or endemics enough to turn into news. I don't know if those viral hemorrhagic syndromes tend to cause sort of a meningeal syndrome. So that's something I would want to look up, and if somebody could kind of tell us in the chat maybe. But the other one I thought of is actually the most common cause of meningitis in sub-Saharan Africa. Anybody know what it is? In the US, it's strep pneumo, right? But there's a thing called the meningitis belt. And what organism sort of accounts for a lot of meningitis there? Yeah, meningococcus, right? So which often causes a severe sort of DIC-like picture. So we don't have the labs here, but and even on exam, you could look at the patient's shins, their extremities, and see if there's their conjunctiva and their palate to see if there's a lot of petechiae, because people with meningococcal meningitis and sepsis often have florid DIC and kind of can have a lot of hemorrhagic complications, including bleeding in the mucosa, including the GI tract. That's I think the empiric antibiotics for that reason were really critical, and we'll see kind of what the rest of the exam and other kind of information tell us. Just to address a couple of the things I saw floating around in the chat and that were mentioned. Tinea solium and neurocysticercosis, absolutely a very common cause of seizures across the world. I practice in Houston that has a very large kind of immigrant population from all over the world. And we actually see this quite a bit of people presenting with seizures, and on brain imaging, they have kind of calcified cysts, sort of very typical kind of radiographic signs of neurocysticercosis. The presentation of that infection, though, is subacute chronic with very minimal sort of inflammatory signs. It shouldn't really cause acute sort of kind of febrile illness and acute meningitis picture from what I know. And then brucellosis, obviously invoked by that social history. Similarly, it often has a more subacute presentation, often kind of a sweaty, jointy vibe. It can involve any organ it wants to, but this would be a pretty atypical presentation. And then typhoid, again, I got curious to kind of look up the frequency with which it sort of has CNS tropism. The abdominal pain fits, diarrhea potentially, but hemorrhagic sort of upper GI, and then CNS frame doesn't quite fit into my illness script, although I'd love to expand my illness script if that is consistent. So yeah, I'm dying to see the vital signs, see the physical exam, and of course have some basic labs, including DIC labs, as well as an LP. So obviously we don't know which way the case is going to go. And El Hadi, please feel free to reveal whatever you were going to reveal, despite our anxiety to know other things. So we'll let's see what you have for us next.
All right. I like the ideas that are going around so far. All right, so this is going to be a pretty big aliquot. On physical exam, the vitals were as following. The blood pressure was 105/62, and this is on noradrenaline. The pulse rate was 125. Respiratory rate was 25. The SpO2 was 96% on mechanical ventilation, and we had to intubate the patient, and his airway was secured with a endotracheal tube. The random blood glucose was 79, and his GCS score was 7 out of 15. His temperature was 39 degrees Celsius. On general exam, he looked ill, and by the time we saw him, he was sedated. His HEENT, on his HEENT exam, his pupils were equal and round with sluggish reactions to light. He had no jaundice, but he had abrasions on the face, and he had a lower lip wound. His mouth was clear there were no petechiae in his buccal mucosa. On cardiovascular exam, he had a normal S1, S2, no murmurs. Pulmonary exam had good air entry bilaterally, no additional sounds. Abdominal exam his abdomen was soft, no organomegaly, and no shifting dullness. On neuro exam, there were no signs of meningeal irritation and no weakness. On extremities and skin exam, he had no rash, but he had multiple skin abrasions on the hands, leg, and back. And when we asked his father about these abrasions, he had mentioned that he had fell from when he had the seizures, he had fell to the ground, and that's where the abrasions came from. I'll go into the initial labs if that's fine. So on initial labs, his white blood cell count was 16,000. Neutrophils were 71% and lymphocytes were 12%. His hemoglobin was initially 14.3, but after a few days in the ICU, had dropped to 10.4. His platelets were 72. The prothrombin time was 28 seconds, and in our labs, the normal was up to 16 seconds. The INR was 2.08. The APTT was 70 seconds, and the normal in our lab was up to 40. The CRP was 52 milligrams per deciliter. The BUN was 49. Creatinine was 1.2. The sodium was 153. Potassium was 3.1. The calcium was 5.8. And of course, because it's Sudan, we had to do one of the first things we did was a blood film for malaria, and then ICT for malaria as well, which were both negative. And I'll go into the liver function tests now. So the AST was 30, the ALT was 52, the ALP was 228, and the total bilirubin was 0.3. And I'll stop there for now.
Sorry about that. Thank you, Al Hadi. Hans, you want to do some interpreting here?
Now, first of all, the vitals. And I think sticking out is the temperature with 39 degrees, which is a fever. Then he has a high heart rate, and he's on pressors, and his blood pressure is still very low, and he only saturates 96%, and that is with mechanical ventilation. Then we have the neuro exam, which was to be expected to have a low GCS, and no meningeal irritation. That is something I cannot yet figure out what it exactly means, but sticking out is his white blood cell count, which is in accordance in same direction of thinking as his temperature. We have 16,000 for white blood cells, and we have neutrophilic predominance, and that might give us a first clue that it could be a bacterial infection, not necessarily, but it's pointing in this direction. And we also have a hypocoagulable state with an INR of 2 and something, and PTT and PT elevated. I think if I'm correct, or is PTT 26, then it would be within normal range. And we have low platelets as well, which is 72. And the next point is we have sodium with 153, and that causes me think about, is he in a hypovolemic state? Maybe not enough vasopressin hormone. I'm not sure, but something causes his sodium to be very high, which does not cause seizures, but it is probably part of his disease state. And otherwise, at this point, these are the pertinent findings that I am PTT 71, as I heard correctly. So we have a hypocoagulable state and hypernatremia and fever. So now I'm looking forward for the LP. Maybe we get a good clue out of there, but before we do an LP, we need a CT to make sure that we have no herniation and we are safe to go with it.
Thanks, Hans. Yeah, absolutely. So you kind of emphasize how sick the patient is. They're very systemically inflamed, sort of septic physiology, right, with the vital signs. And obviously the CNS is very sick. We already knew that. It is a bit surprising that the neck isn't sort of more obviously stiff, but I wouldn't count on that as a sensitive sign to necessarily rule out our pre-test suspicion, right? That being said, it does make me wonder even more to want to make sure there's no inflammation like within a parenchyma of the brain. Again, this might be a predominantly encephalitic picture rather than a meningitic. There's always a spectrum between the two, or it could just be an entirely intraparenchymal picture, right? This could just be a brain abscess, for example. But we definitely need the LP. We definitely need brain imaging, the sort of the latter point. And then the potential sort of concern for DIC is panning out with the labs that you pointed out. And again, that picture is not specific to any one infectious etiology, right? It could just be a manifestation of any cause of bacterial sepsis, for example. The malaria, I think, Anne-Marie, I noticed sort of wanting to make sure that we've gotten a couple of serial tests. I don't know, El-Hadi, like I suspect y'all are very good at testing for malaria. So if you're saying it was negative, it probably includes, right, multiple smears if needed in a PCR. So I'm going to kind of hang my hat on that for now. But please let us know if it's not the case. And yeah, Yusuf, so tell us what you're thinking there.
Yeah, the thing that catches my eye the most is the elevated white count, the anemia, the thrombocytopenia, and the elevated INR and PTT. And thinking of those things, any raging bacterial infection, like even strep, staph, Neisseria, can cause DIC. But in addition to those, I'm also considering viral hemorrhagic infections, which can also mimic this presentation. So in general, I would upfront want to cover for, I'm thinking of infections that can cause the AC or any bacterial bacteremia like strep that can cause this. So I would want to cover for those organisms, get cultures early. And I'm also thinking of the viral etiology. So I would think about PCRs or how to send those. And I wanted to ask you, is it your practice to start dexamethasone empirically for these patients, or do you hold off depending on your suspicion of the organism? I know there was like a JAMA review that recommended starting dexamethasone for all patients with meningitis except if it's listeria, but I don't know if with this patient-specific demographic or like from their presence in Sudan, would that change your practice? I'm not sure. Or is it your practice to start it anyway?
So in the US, yes, I believe the data as well as the guidelines say that if you suspect bacterial meningitis, based on the clinical presentation and initial LP results showing a sort of a high white cell count with predominantly neutrophils, right? You should start dexamethasone empirically. That is based on data that pneumococcal meningitis treated with dexamethasone early, like sort of co-administered with first dose of antibiotics, really improves outcomes, neurologic long-term outcomes. So if it turns out to be another organism, there's not sort of specific data that the steroids help. But because at least in the US, the most common cause is strep pneumo, it's recommended that before you've sort of definitively isolated the organism, you treat all bacterial meningitis up front with antibiotics and dexamethasone. I don't know whether that risk-benefit kind of judgment breaks down when you have a different microbiologic kind of breakdown of likely causes. So if someone knows, please share whether, for example, in sub-Saharan Africa, it's the same recommendation. Okay, so yeah, not much more to add. Great discussion. Looking forward to hearing the next aliquot, El Hadi, and catching up a little bit with the great pearls in the chat.
All right, so I'm not an expert on treating meningitis, but this patient was given dexamethasone, and strep pneumo is also a cause of meningitis in Sudan as well. Despite Neisseria meningitis also being a common cause in Sudan. I think in this patient, Neisseria meningitis is more common in this age in Sudan, but generally speaking, the patient did receive dexamethasone. Yeah, I'll move on and I'll go into the additional labs that were taken and the imaging that was done. So we got a cranial CT that showed generalized cerebral edema. The blood cultures were negative. They didn't grow anything. The viral serology showed a hepatitis B surface antigen that was negative. It was negative. HIV 1 and 2 ELISA were negative, and anti-HCV antibodies were also negative. There was a lumbar puncture that was done that showed a normal glucose, elevated proteins, and lymphocytic pleocytosis. And the gram stain that was done on the lumbar puncture was also negative. A ANA was done and was negative. A urine toxicology screen was also negative. And I'll stop here for now.
Thank you, El Hadi. Wow. Yusuf, we asked and we received. We have brain imaging, we have an LP, and we have some extra labs that are really helpful. What do you make of all of those?
Yeah, thank you, El Hadi. So just before I start with the LP, I was just wondering if the hypernatremia and hypokalemia could be a hint towards Waterhouse-Friderichsen syndrome, but this is just an extra thought, and I know I would want to cover for it up front either way with antimicrobials. In regards to the lumbar puncture, it lymphocytic predominant with elevated protein and normal glucose. Usually with lymphocytes, I think of fungal etiologies, tuberculosis, viral etiologies, and other things that are more subacute, like sarcoid malignancy, sometimes syphilis, and even Lyme disease. But given the hyperacuity, I'm prioritizing viral and bacterial causes and even fungal causes. And even I don't think it's sensitive enough to make, I think some bacterial infections early in the course, if you get early enough, might be lymphocytic and then it turns neutrophilic, I believe. The glucose is normal, and usually with the bacterial and fungal infections, the way I imagine it is that the organisms eat the glucose and it's typically low. And this pattern is typically more seen with viral etiologies. So this is what I'm prioritizing. So I'm thinking of if there's like a PCR test that we can send, or if there are any viral tests that we can send, that would be my next priority, along with starting empiric acyclovir upfront as well.
Love it. Thank you. I think HSV is really important to think about, right? It's a viral etiology of meningitis and encephalitis that is very bad, and that we have a treatment for. So herpes viruses, including varicella zoster as well, you know, are really important to test for and to treat empirically, potentially before you've even confirmed, although the testing usually comes back pretty quickly, at least the PCRs, if they're available. Yeah, I think the LP is extremely helpful, right? So, you know, our pretest of this being bacterial meningitis has pretty much, you know, gone down close to zero with finding lymphocytes rather than neutrophils. So if you see neutrophils, like you alluded to early on, it could be the first response to a non-bacterial process. But if you see lymphocytes and no neutrophils, and I'm also curious, El-Hadi, if you have it, what the number of white cells was. That's not consistent with bacterial meningitis. And then it sort of opens up a lot of other causes, viral and then non-infectious causes of meningitis. So I think this really prioritizes still in a hyperacute, systemically ill, febrile setting with DIC. We're still mostly in the world of infection. And then the type of infection, we're in the world of mostly viruses, considering again the acuity, with a possibility of fungal or mycobacterial, but probably less likely just because of how sudden this was, and the fact that it's essentially the combination of like a CT with the lymphocytic pleocytosis and the absence of meningismus. This is almost more prominently encephalitis than it is meningitis, isn't it? Just a sort of disproportion again of how badly affected the brain is swollen, as evident on CT, and seizing all the time, right? And then you have DIC with clinically significant bleeding. So to me, we're kind of entering more deeply into the potential world of hemorrhagic, viral hemorrhagic fevers. I think, to my knowledge, the treatment of which is mostly supportive, which don't, by the way, underestimate just how vital and life-saving that can be, right? Whether that's hemodynamic support like we're currently doing, respiratory support like we're currently doing, management of intracranial pressure, like the serum sodium is self-doing, if that was the presenting serum sodium. But with all the infusions and other things, as well as with the almost certain high ADH state that is going to result in this patient, given you're going to have to keep an eye on that, right? In a couple of days, that sodium could easily be 130, and whereas you want it to be high if there's signs of cerebral edema, right? the supportive care in terms of bleeding and support of sort of coagulation functions, right? Again, all of that can be vital and save the patient's life, even if there's no pathogen-directed treatments. But there's also other considerations of containing this infection and not letting it other people get sick. And I'd have to do a lot of kind of point of care learning if I were managing this patient in terms of, again, better understanding the specific pathogens that can cause a disease like this, whether it's some of the ones that we've sort of said out loud, like Ebola or dengue or some of the other viral hemorrhagic fevers that can happen in different parts of the world. But yeah, what kind of isolation precautions are needed? What kind of precautions the laboratory needs to take with all specimens, right? That's really, really critical in helping protect not only this patient, but those around them. As well as, again, what kind of exposures others have had to the patient outside the hospital and what sort of precautions need to be taken to protect them as well. So I want to actually just open it up for Hans as well as everybody else to kind of weigh in and potentially verbalize important things from the chat or just any other thoughts, because this has quickly become all right. I mean, from the beginning, this has been a patient who was very sick and complicated. But I think with some of the negative studies we've gotten in terms of the LP results as well as the blood cultures, this has become a patient that I know the diagnosis is one that I'm not used to making and not used to treating. So I'd love the wisdom of the crowd if people have other thoughts here.
And I would just repeat what you just said. Much of of the lab results seems to indicate that we might face, just with caution, a possible viral encephalitis causing DIC, necessitating supportive measures, in particularly lowering intracranial pressure. And I think his epilepsy might be under control while he's in the ICU with the measures that are being taken there with propofol. So in that case, and it was mentioned in the chat, we have probably a PCR panel where we are looking at the most prevalent viruses in that area. West Nile was mentioned, dengue. I had a case in Muskoka which was an East equine encephalitis virus, which caused us big trouble. It was diagnosed in the States because we were totally not familiar with it. This was a mosquito-borne virus that got into our area further north than expected because of climate change. So something unexpected is what I'm expecting now.
Thanks, Hans. Does anyone know if dengue, so I know dengue can cause thrombocytopenia and it can cause capillary fragility. So you can have, petechiae and other sort of hemorrhagic manifestations through that mechanism. Is it prone to causing DIC like some other hemorrhagic viruses are? Anyway, that's something I'm just curious to look up, but is probably a little peripheral to immediate management in this case. All right, El Hadi, tell us more. And I guess someone was asking, but I'm curious too. Is there are you going to reveal the diagnosis now, or is there more things that happen for this patient?
All right, so I'll add a little bit more information before revealing the final diagnosis.
Sounds good.
But just keep in mind that we were practicing in a quite a low resource setting, and we couldn't do as many all the tests that we wanted to do. We managed to narrow it down a lot. but at the end, we couldn't do a lot of the tests that we would have liked to do and to get to the final diagnosis. So to address what Yusuf asked about, we did give the patient empirical acyclovir, but on PCR of his lumbar puncture, his PCR was negative for HSV on lumbar puncture. And if you don't have anything to add, I'll go into revealing a little bit more of what we did at this point. So we had taken serology for a dengue fever, and the serology had returned negative at this point. Yeah, so if you want to discuss this a little bit more, you can discuss it, and then I can reveal the final diagnosis, or what we assume to be the final diagnosis.
Honestly, Elhadi, I think we've had a really nice discussion, and maybe we can get to the diagnosis and then have a little more extra time to reflect in retrospect and learn from everybody, as well as the teaching points.
All right. It was a very difficult case, especially because the family didn't have the financial resources to do all the tests that we wanted to have done. But we ended up narrowing it down to a viral meningoencephalitis and hemorrhagic fever of an unknown viral agent. That being said, because of the epidemiological factors in Sudan, Rift Valley fever was considered as a possible diagnosis, but dengue fever was still possible even though the serology was negative. So to give a little bit of background, Rift Valley fever is endemic in Sudan, and there have been several outbreaks in the past few years. The closest one has been in 2020. Another factor is that he has close contact at home with goats, and goats are commonly infected with Rift Valley fever virus in endemic areas, and any contact with any animal products from goats or an infected animal can lead to infection. An alternative explanation is that the negative dengue tests is because of the timing of the serological tests. So the IgM serology starts to become positive approximately 4 days after the onset of fever, and our samples were taken on day 4 when the IgM may have still been undetectable. To talk a little bit about the patient outcome, the patient recovered after 8 days in the ICU. He recovered fully. He was discharged without any neurological sequelae. The patient was later lost to follow-up. And his family, like I mentioned, his family refused to pursue any further testing because of the financial strain. I have some teaching points prepared, but if you want to talk about it now, I can say them a bit later.
The iron is hot. Strike.
Okay, the teaching points are that dengue and Rift Valley fever are both transmitted by the same vector, and that is Aedes mosquitoes. Aedes mosquitoes are, of course, in Sudan. Both have a wide spectrum of clinical presentations, and both can be febrile illnesses that have the potential to cause a meningoencephalitic picture in severe illness. Rift Valley fever is endemic to East Africa and the Middle East, and can also be transmitted by the ingestion of unpasteurized and uncooked animal products, but as well as through aerosolization during the slaughter of infected animals. Lastly, the NS1 antigen test for dengue infection has a high sensitivity and a high specificity for dengue fever, especially in primary infections, and can be detected early in the onset of illness, but only remains detectable for up to 9 days. So at that point, it would be better to pursue serological testing to secure the diagnosis. Yeah, that's basically most of what I have.
Thank you for that. I was taking notes on the side with into my little learning document. But yeah, thanks for that incredible case and masterful presentation, Al-Hadi. I'm curious if Hans, Yusuf, if y'all kind of have any retrospective analysis or remaining questions about this case.
for me, it's like we mentioned, the importance of starting empiric therapy early and then trying to figure out what the etiology is. And like you mentioned, a lot of those organisms, the treatment is supportive, like anti-epileptics, platelet transfusion, and supporting the patient, and in the meantime, waiting to find the answer. So I was trying to think retrospectively if there's anything else we could have done. I think it's a very, very hard case. It's an amazing case, Al-Hadi. Thank you so much for bringing it. I can't wait to learn about the different hemorrhagic fevers, and I'm sure it's every area in the world has a different cause of hemorrhagic fevers. So thank you for adding one more to my armamentarium.
Thank you guys for letting me present. I've loved presenting. So my first time presenting, hopefully it's the first of many, and it was really, really exciting.
It was outstanding. Thank you, Hadi. Hans, were you gonna reflect on anything?
Yes, for me it was, as so often in VMR, the path towards the diagnosis, even though we have not clinched the exact diagnosis at this point because further investigations could not be conducted any further. It was the way getting there, looking at the lab values, seeing a low platelet, high sodium, high white blood cell count, neutrophilic, so that we eventually with the LP and the CT, which showed edema in the brain, and the LP lymphocytic pleocytosis, that we are probably handling an unknown virus. And I think the second thing that I learned was how to manage such a severely sick patient with DIC possibly, and then of course further investigate what we can do in our society where we do have the resources to figure out what it could be. And of course I've learned from another country like Sudan something entirely new, which is amazing. Thank you.
Thanks, Hans. Yeah, wonderful case. I think the destination was obviously a fascinating disease that most of us have never seen, but the journey included a lot of great common problems and fantastic discussion from Hans and Yusuf and in the chat. So thank you, everybody. Tansu, do you want to take us home with the teaching points? And special shout out to Jimena too for scribing. And yeah, let's hear the summary, Tansu.
Sure. Thank you so much. And this is the benefit of having a global community. We get to learn from patients from all over the world and doctors from all over the world. So thank you so much, Al-Hadi, for bringing this case for us. So our patient was a young 18-year-old male patient who presented with loss of consciousness. And when patients come with loss of consciousness, treatment takes the foreground over diagnosis. And we first have to scan the patient. So we check the sugar, get a head CT, check the arterial or venous blood gas, and if we are suspecting opioid overdose, we give Narcan to the patients. And then we assess for the 5 S's. In young patients, idiopathic primary epilepsy is a consideration, but with the fever and acute time course of this patient's presentation, we were suspicious of infection, metabolic and toxic causes as well. In older patients, on the other hand, the base rate is it more favors intracranial processes such as tumors, ischemic, and hemorrhagic strokes. And we learned from Yosef and Yaz that neurocysticercosis is the #1 acquired cause of seizures worldwide, but it's less likely as the presentation of this patient is more subacute to chronic with minimal inflammation. And since the patient had fever, neck pain, loss of consciousness, and seizures, we started prioritizing meningitis here, meningitis and encephalitis. And the most common cause of meningitis in the sub-Saharan Africa in the meningitis belt is meningococcus. Zaven caught early on that with the patient's coffee ground emesis is that secondary to retching while the patient was vomiting when he was having the abdominal pain and diarrhea, or another process going on, such as DIC. And when we found out that the patient had high PTT, INR, and low platelets, we entered the world of DIC as well. And Hans mentioned that we should get CT before LP, especially because this patient had altered mental status, and we can remember the cause for the reasons for why we should get CT before LP with TAP as if mnemonic. And since we saw that the patient had a swollen brain on the CT, we started thinking that probably we are in the world of encephalitis rather than meningitis. And when we think about the bacterial and viral hemorrhagic etiologies that can cause both DIC and encephalitis, it's important to get cultures early and send PCRs for viral etiologies. And pneumococcal meningitis is treated with dexamethasone early on in addition to the antibiotics. And it's important to give the dexamethasone right before or with antibiotics. That improves neurological outcomes, especially in the pneumococcal meningitis, which is the most common etiology of meningitis in the US. And the patient's age and the epidemiology of meningitis in Sudan pointed us towards more Neisseria, but the patient still got dexamethasone. And on the LP results, we saw that there was a lymphocytic predominance that points us towards fungal, TB, viral, sarcoid, malignant etiologies, as well as syphilis and Lyme. But when we layer on the acute time course and the low glucose, normal glucose, we started thinking more about viral etiologies. And here the differential diagnosis included HSV, VZV, dengue, West Nile virus, hantavirus, Ebola, Crimean Congo, and Rift Valley fever. And in the end, the diagnosis was because of an unknown viral etiology, but there was a high suspicion for Rift Valley fever, secondary to common outbreaks in Sudan, and the patient's close contact with goats. And the timing of serological tests on day 1 can be a little misleading because IgM may still be undetectable in that time period. And thank you so much. I hope you all have a great day.
So that was a wonderful summary. Thank you. Thanks again, everybody, for sharing and teaching about this case. Have a great day.